let's do this then. Okay, so we've just got a little bit of housekeeping then. So good evening, everyone, and welcome to the Body Doctor webinar hosted by our Learning and Development Manager, Mussa. Please note that the webinar content will be recorded, and as attendees, you will be muted and can only be unmuted by one of the panelists. Please type your questions into the chat function and we will conduct a Q&A at the end. Once the webinar is finished, there will be a short survey, so please answer honestly so we can continue to improve these sessions. Following this, you'll receive a thank you email with a link to download your CPD certificate, so please keep an eye out for this as well. Presenting this evening is Mussa. Ros is a highly skilled professional with over 30 years experience in the industry. In practice, she works as a CLO with a special interest in dry eye disease management and is long-standing advocate for peer-to-peer learning and professional development. To really highlight the interest and enthusiasm for dry eye disease management, Ros works closely with the Body Doctor as our Learning and Development Manager, enhancing our CPD offerings. Ros will be discussing with us the CPD lecture titled Demodex, Friend or Foe. So welcome to everyone again. Thank you for your time this evening, and over to Ros.
Hello and good evening. Welcome to a CPD webinar, Demodex, Friend or Foe. My name is Ros Mussa. As Barry's explained, I'm a contact lens optician and the Learning and Development Manager for the Body Doctor. I've always been very heavily involved in education, but I've always worked in practice at the same time. High interest in dry eye disease. I don't think you can really fit a contact lens without having an interest in dry eye disease or dry eye management. So that's really where a lot of the webinars are coming from and written from, very much a practical point of view. So the webinars today is a lecture, and it has been written in line with guidance from our GOC, FBDO and our professional bodies. And the C number and the QR code, do not worry if you haven't got them, because we will send you an email at the end of the webinar and that will all be listed on there. Okay, so let's begin. So I kind of always think it's good to start right at the beginning, and I kind of think about the eye, and whenever you Google the eye, it's actually a relatively simple structure with really high functionality. And prior to scanning, because now we have great scanning equipment, OCT, Optimax, etc., our refraction was really, really important in that, because it would tell you about the functionality of the inside of the eye. So and if you think about refraction, actually, where does it come from? It comes from the anterior eye, and 60% of your refractive error comes from the front surface of the eye, and 30% of that refractive error, of that 60%, comes from your tear film. So you can see straight away, if that tear film is unstable or not functioning very well, then it's going to have a real effect on your refractive error. So the anterior eye is the only part of the globe that's exposed to the environment and all the influences that brings to bear. It's also based in a highly organized and very sophisticated structure, the tear film. And the tear film is actually essentially 2 layers. I know we've always had it as 3, and it doesn't really matter. We can still explain it as 3 for ease, but it is actually 2, and this diagram here depicts it really well. So the lipid layer is made by those all-important meibomian glands producing polar and non-polar lipids. The aqueous layer being produced by your lacrimal gland, which is filtering the blood plasma and pumping, the bulk of the tear film, which is the aqueous, onto the front surface of the eye. And the mucus layer, which is produced by your goblet cells on your palpebral and bulbar conjunctiva, so the palpebral above the cornea. And then we've got this all-important structure, the glycocalyx, which is a carbon-rich coating that goes a long way to having a stabilizing function for the tear film. And beyond that, it stops any bacteria adhering to the cornea and colonizing, etc. So it's actually a very important structure as well. And that pH level of the tear film is approximately 7, produced by the glycoproteins of the aqueous. And essentially, the tear film, if we think about it, is a dynamic structure. And what I mean by that is if one layer starts to get affected or fails, then it will affect the others too. So it's really important to think about the tear fluid in that way, that we don't just if it's the lipid layer that we see failing, that we don't just address the lipid layer, we'd probably also choose a drop or some kind of management that has some aid for the other layers as well. Okay, so when we're talking about functions that are failing, we look at DEWS and DEWS2. Well, DEWS was actually an international study, and it's given us management, structure and recognition to dry eye disease. And we can see here as the DEWS has evolved in its understanding and the Bibles, if you like, that we get from that, you can see the difference in understanding. So initially in 2007, when the DEWS report was released, we had a definition that really was definitely a multifactorial disease, a disease being a malfunction, but it really concentrated on the symptomology and touched on the fact that there was inflammation of the ocular surface. If we look at how our understanding has evolved in 2017, it's definitely still a disease. We know it's definitely still a malfunctioning issue, so that's what a disease is, but it looks at the fact that there's a loss of homeostasis, with the key component being hyperosmolarity. So what is homeostasis? It is an easy example of that would be our body to maintain its temperature irrespective of surroundings, and we do things to aid that. So if it's really cold, we'll put on gloves and coats and scarves and warmer clothing, and if it's really hot, we would wear something that's much looser and much cooler and not so many layers. So that's a way of aiding homeostasis. And our drops, like in the market, that will be a way of aiding homeostasis for the tear film. And there's lots of other things we can do as well. But obviously that's just an easy understanding of what's going on there. And then if we think about what is one of the most common conditions that we see, so like a precursor, if you like, to dry eye, we're looking at blepharitis. And we know, if you're looking down the slit lamp, 9 times out of 10, you're going to see some level of blepharitis. And what is it? It's a chronic inflammation of the eyelid margin. And meibomian gland dysfunction, highly prevalent and the leading cause to evaporative dry eye. And often, even if you think the meibomian glands are okay, and if you go to press them and suddenly you find that something's not coming out that easily, or you have to press a little bit harder, that's non-obvious MGD. So that's your early stages of meibomian gland dysfunction. So I always encourage everybody to please press those glands. But how is Demodex associated with both of these? Because it is. So that's what we're really going to look at next. So let's first of all look at the relationship between blepharitis and dry eye disease. So what are we talking about? We're talking about the quality of the meibum that's produced and the quantity that's produced as well. We know that we've got blepharitis is the inflammation of the eyelid, and you can see that the two are clearly linked. So you have inflamed eyelids, and that means that the opening of the meibomian glands is under more pressure and things can't get out as easily. And so therefore you have a reduced output of the from the meibomian gland, producing an ineffective layer, and that gives rise to evaporative dry eye. So homeostasis is starting to break down at that point, and inflammation starts to occur. But is Demodex here involved or not? Well, let's have a little bit of a look. Well, let's understand Demodex before that. Is it good or not? Which is why we're all on this call, right? Well, every single person on this call has Demodex because they're a natural part of the human environment, and they serve a really useful function, actually, feeding on dead skin and oils and helping get rid of face waste. And they're fine as long as their numbers stay low, and they're pretty harmless. So we can definitely establish they're necessary and endemic. Well, what happens as our numbers get higher? Well, let's understand something. Well, Demodex mites in eyelid tissue we realize they were there since 1876, but their association with blepharitis wasn't established till 1967. So there's quite a difference between that time. So you can see that there really wasn't much understanding around Demodex. As we've started to evaluate and studies have come along, there's been a lot of oral, topical, and eyelid hygiene devices based on the options. We're trying to understand the functionality of Demodex and what it's doing. And in 2014, the FDA approved ivermectin for Demodex management, and in 2023 the FDA approved another drug which is used more in the States, I believe, latanula, an antiparasitic drug generally used by vets. So we're starting to understand that Demodex definitely, by keeping its numbers down, we can definitely have a positive effect on its effect and its association with Demodex, with blepharitis rather. So there's actually 8 types of Demodex, but only 2 types live on human beings: the Demodex follicularum, and or I call it folly for ease, and Demodex brevis. They have 8 claws that they use for locomotion, and they tend to move around at night. They're the cousin of the spider or the mite and the tick. And as we've established, their prevalence increases with age, and that's because when you have blepharitis there, it's kind of used as a bit of a shelf, as a bit of a barrier for them to hide underneath and kind of and to kind of grow in their numbers. And when you have a patient that has got a depressed immune system or a steroid user, that's another kind of prerequisite for them to grow more in their numbers. So it's kind of like as the area becomes more diseased, the Demodex numbers start to grow. So what do we know about blepharitis and the ways in which Demodex kind of influence that? Well, there's direct mechanical damage because they chew on the sebum. Those bite marks kind of like have a little bit of an abrasive effect, and they sort of like damage the skin. Also, by the way they're moving around, they damage the skin, and in that way there is hyperkeratinization that occurs, as in the skin trying to protect itself by thickening up. And then you have they're a vector for bacteria, so the bacteria that they carry kind of like induces hypersensitivity and inflammation. So the more Demodex there is there, the more bacteria is there, the more hypersensitivity there, and the more inflammation there is there. And that's when you get patients starting to rub their lids and actually making things even worse. And we know, as we've already covered, that there's an increase with age and with different conditions, rosacea and diabetes. So the thing to know about blepharitis, yes, there's different types, allergic, seborrheic, etc. But actually, the most common is actually the Demodex mite infestation. So that's something to really bear in mind. So more often than not, you're going to get Demodex associated with blepharitis. And the good thing for us is, especially over the last 5 years, the number of published articles around Demodex has increased. And so our understanding is getting better and better. So what do we see down the slit lamp, for example, when there's Demodex? Well, you'll see these collarettes, and they're a result of overgrowth of the Demodex, and that is meibum. It's going to have dead skin in there. It's going to have eggs. It's going to have possibly a few mites. You will definitely see misdirected lashes, lash loss. And there's patients that come in with recurrent chalasia. These are all signs that you've got Demodex in play. And what the patient tends to report is itchiness, soreness, redness. Those lids are actually quite red, and crustiness of the lid margins. Definitely more morning discomfort, and that's because that's when the Demodex are kind of clawing back in, and the eyelids running. And do remember, around the collarettes is actually where the Demodex lay their eggs, so that's the hatching site as well. So if you can do something about that, you're definitely going to be breaking that cycle of Demodex kind of reproduce that reproductive cycle that we're trying to break. But there's many different options on the market, and it's really about knowing what to use, or actually knowing why you're using it. And the objective really is to break that reproductive cycle, because we know we need them there. We just don't need them there in so many numbers. So we need to break that down. So we need to break down that reproductive cycle so you have less, and then they reproduce less, and therefore they're doing their good job without actually causing any harm. So these are just some of the things that are out there on the market at the moment, and let's have a look at them in a little bit more detail. So hypochlorous acid, it's highly underused and actually a really, really good eyelid hygiene spray. What does it do in the body? It is a weak acid that is responsible in oxidative response. It's made of hydrogen, oxygen, and chlorine, and it is housed in the white blood cells. So the white blood cell comes in, and what does it do? It engulfs the bacteria, and then the hypochlorous acid basically destabilizes it and kills it. So so that's really how it works. So it keeps the number. So it keeps the harmony in place, if you like. And a lot of my patients use this, for example, as a toner, right? Because a lot of toners have alcohol in it to clean the skin. This does it just as well. So you can see straight away that it is a harmonizer, and it doesn't kill Demodex. What it probably does is it actually makes sure that the environment isn't as conducive to having Demodex live on it. And if we look at it, what's in the bottle, what do we have actually out in the market at the moment? These are the three that we have. So what's the take-home messages? It's antimicrobial, anti-inflammatory. It reduces inflammation and is keying blepharitis management, and it's a gentle, non-toxic atomizer spray. So really, really useful, really easy for those patients with poor dexterity, because they're not trying to aim it anywhere. They just close their eyes and spray, and it goes everywhere, and it dries. You don't wash it off, and it's great. It does the job at reducing blepharitis. The other one that we know quite a lot about, and everybody knows quite a lot about, is tea tree oil. Okay, it's been for a long time associated with keeping Demodex numbers down. It's antibacterial, antifungal, anti-inflammatory, but the problem is it may be harmful to ocular tissues. So what is the active ingredient in tea tree oil? Is T4-ol, and that's the thing that actually does the good, and it has a greater mycocidal effect than tea tree oil alone, with less irritation. And what are we really saying there? It's probably easier if I show you this slide, and it shows you that they both do the job. They both kind of kill Demodex, but the T4-ol does it much quicker than tea tree oil. So you're exposed to the harmful effects for a lot less time, which is probably what we're looking for, isn't it, really? We want to kill the Demodex, but without doing any harm. So maybe T4-ol might be the direction to go in. And I've just here again shown you a few things that are on the market. So you've got tea tree oil wipes, you've got a gel, and these two over here, Demex and Blepharitis, they really use that ingredient T4-ol. So again, it's about knowing your products that are out there and knowing how they use and knowing what to use. And then the other guy that we have on the like in the game is the okra with Demodex management. Okra does exactly the same as tea tree oil. It eradicates the Demodex in exactly the same time frame, but as you can see here, with significantly less corneal staining, i.e., significantly less damage to the ocular tissues. So that's that's probably a bit of a game changer from that point of view. It is, if we look at okra, it is a polysaccharide, and it has a lot of flavonoids in it, which are rich in antioxidants, and also is really rich in tannins, really good for abolishing bacteria. And the way the polysaccharide works is it inhibits cytokine action. Okay, so if we think about what's happening here, is it's as homeostasis breaks down the cornea sends a message to the lacrimal gland, and the lacrimal gland sends out aqueous fluid with more inflammatory markers in it, because it wants to start dealing with the inflammation that's coming. So what the polysaccharide does is it inhibits that cytokine reaction. It kind of brings it down, a bit like an ibuprofen does. It just reduces that inflammation. You've still got inflammation there, but it's not getting out of hand. So it makes the area appear to be less diseased, and therefore an environment that isn't as conducive to the Demodex, along with the fact that it's a really good antioxidant and a really good, with having all those tannins, really good at abolishing bacteria. And if you actually want to measure that, we can do that. So when you get that kind of stress, you get MMP9 being released, which is an inflammatory, and you can actually measure that using an inflammadry. So you can see when you use an inflammadry, you've got heightened MMP9 action, and then after you've used something which has ochre in it, then you will have a reduction in the MMP9. So you can see straight away that inflammation is left, and you can see the area is much cleaner. So what are the products on the market that have ochre in them? It's these guys. It's the Zoccular system. So that's ochre technology. So I'm nowhere am I advocating that you go out and buy a load of ochre and start smearing it all over your eyes. Not at all. You need to have it probably more measured in its management. So you have foams, you have wipes, and you have the Zoccular Shield, which is like a pump. And then you have the in-house treatment, which is the Zest. And we're going to be talking about that pretty soon, or just now, actually. So if we move on to the in-practice treatment, it's not new. We've been using Gulf buds since the 60s to try and, remove that that scum that's produced in in blepharitis, which houses Demodex. But again, that damages the tissue surrounding. So we only used to use that until it was absolutely necessary. But that whole microabrasion we know is very, very important and very useful, because as soon as you start to remove that, then you actually break the cycle just by the fact that the eggs are being thrown away, and therefore they're not going to hatch, and therefore you've got that automatic break. So what do we use instead? We have new lids and we have blepharitis. And it's really important to understand that even, if a patient comes in and has had new lids and it's completely, or blepharitis, whichever of the two, has had those two, and you've cleaned away that scum, and they come back in 6 months and it doesn't look as heavy as this, it doesn't mean you don't do it, because the Demodex and the blepharitis will start to build up again. So therefore, take it back again. Don't let that cycle come back to the same extent. So even if it's not as heavy, still go in and get rid of it. Then we move to the Zest system. So this is actually a really clever system. It absolutely microdebrides, and on top of that, it cleans. And because it has that inhibiting cytokine action, it really reduces the discomfort as well. So it has that kind of knock-on effect of kind of reducing that inflammation and making it appear less conducive to Demodex, to wanting to live. And if you top that up with some Zoccular technology to keep it maintained, you'll really keep that area clean and really keep the Demodex down. And then you have IPL, the multifactorial answer to a multifactorial disease, if you like. So this will, just by the amount of energy that's radiated and the Demodex absorbing that, it just cannot survive. But do remember, it will only kill the Demodex on the skin. So hopefully that's given you a bit of an idea of the two types of ways that we can manage Demodex. For me, I tend to do in-house with a little bit of in-house management with a little bit of at-home management, because nobody really maintains to the extent that they do. Think about it from a dentist point of view. We all start off after we've been to the dentist doing the flossing, and then it wanes, and then we kind of stop, and thank God we go back to the hygienist, and it's kind of exactly the same principle. Do your management in practice, and then don't give them anything too complex. Bit of hypochlorous, bit of T4ol, Demex or Zoccular Shield or something to keep everything down. And you'll find that everything is a lot better managed and the patient feels a lot more comfortable. So the answer to this is Demodex friend or foe? Well, it's a double-edged sword. We need them, so they're definitely a friend, but it's their numbers get out of hand, then they're not such a good friend and they start causing us a problem. So we need to keep those numbers down. So they're endemic and they're necessary, so we don't want to obliterate them completely, and that's why it is management. And their numbers do need managing. So hopefully I've given you some tools to understand how to manage and understand how they have a job to play with blepharitis, and how they're actually really prevalent with MGD and blepharitis, and they really can be a menace if they get out of hand, and there's some predisposing factors. Anyway, thank you very much for taking time to listen to this webinar, and hopefully I'll see you again on the next one. Take care now. Bye-bye.
The notes.
We just had a question come up.
Here we go. Yes. Yeah. If you can see that, Ros. Yeah. How do you tell a patient they have Demodex?
Okay, let's go back to this slide here. If you're looking down the slit lamp, you can see the collarettes. And when you do your history and symptoms, the patient reports itching, soreness, redness, crusting of the lid margins, bit of blurred vision. The biggest giveaway I tend to find is when you talk to the patients a lot more, they'll tend to say that their eyes feel worse in the morning. And that's a sign that because the Demodex come out overnight, so they're going to be clawing up that duct and causing that little bit of irritation as they come out and doing the same as they go back in. So they'll definitely feel that in the morning a lot more. And you get that running and you get that redness along the lid margins. You get that real kind of, if you look around the opening of the meibomian glands, there's those tange vessels, which are there because of inflammation that the Demodex is causing. Remember what we said. Sorry, I missed that last question, Barry. I can see Elizabeth asked another question.
Yeah, so how do you tell a patient that they have it? Stevens asks, is there a recognised scale that can be used to grade Demodex severity? And then Elizabeth's written, I had a patient yesterday, I could clearly see she has Demodex, but finding a way to tell the patient they have bugs on their eyelids, that's what she wants to know. How in a nice way can you tell them that they have them? But right. I guess that answers you said that, you know, it's a double-edged sword. We sometimes need them and we also need to manage them.
Yeah, so we absolutely need them, that's without a doubt. So the way that I tend to explain it to patients is I say, look, there's natural fauna and flora that actually live on the skin. They've got to be there, they do a good job, but actually the numbers of them can sometimes increase to a point where it's not great and you start to get discomfort. So I tend to explain it like that. And I kind of explain it in the dentistry terms. I kind of say, look, the bacteria that live around our teeth are supposed to be there. They do a good job. But if we don't clean them away, if we don't brush our teeth, their numbers increase and they start infecting the glands and start causing problems. So that's kind of where we are with your eyes, and that's what we're seeing here. And this stuff that is actually along the base of the lash is actually biofilm, and it's exactly the same as plaque. So it basically causes a shelf that actually a lot of the traditional treatments can't get through, and therefore really allows an environment for the Demodex to thrive and grow. So I explain it in that way. Does that help, Elizabeth?
Yes, thank you. And is there a recognisable scale, Ros?
There's a few. There's not a scale like the CCLRU or the Efron scale or anything like that, but there's a couple of scales that are pinging around the place, but there's no real gold standard as yet. So I think until there is something like that, then maybe there will be in the Deuce 3 report. Hopefully there will be one there. But until there is something like that, maybe find one that your practice likes to use and that everyone can reference and you're all on the same page. That probably would be quite useful. There was another question that came in from Jig, and I just missed that, unfortunately.
Yeah, no, that one says, does blepharitis work on Demodex management at all? And would we suggest an alternative management for patients that are already on this? So I think
if we think about what blepharitis does, it hasn't actually got any of the agents in it that are, if we look at the agents that are, let's go back to this, right? So if we look at the agents that are actually useful for actually eradicating Demodex, you've really got tea tree oil and you've got T4 which you take out of tea tree oil, and you've got okra. Those are the things that actually kill Demodex. Then you've got things that will actually make the environment less conducive for Demodex to live. That's your hypochlorous. Things like blepharitis is a great cleaning agent, and it will clean the lashes. It won't, and if you've broken down that biofilm a bit, then their blepharitis will help. But it's not actually designed to kill Demodex. Does that answer your question? You're probably, if I had the option of using something that was T4Ol or okra based over blephosol for Demodex, I'd definitely use those two, without a doubt, because they will manage the situation so much better than something that isn't designed for it, i.e. blephosol or blephaclean.
Excellent. Okay, says thank you. Anna asks if you could just tell them a little bit more, about Zest.
Sure. So the Zoccola system, so we're talking about okra-based systems here, are what would you like to know about? What would you like to know? Can you expand a little bit? Just give me a bit more.
Okay. Here we go.
Okay, I understand how it mechanically works. Okay, so if we go to the Zest or any of the Zoccola-based systems, they are okra-based. And what you do with the Zest system is you've got these little ones that look a little bit like my pencil, and you literally create there's a little packet within it which has the solution, the magic solution as I call it when I'm speaking to my patients. You pump that out into these little containers that look like contact lens containers, and you literally wipe that onto the lids, and then you rub, almost like making it like a shampoo, and then you roll the wand through the lashes. It has almost like a micellar effect, cleaning effect, and you rub that also along the lid margins around the opening of the meibomian gland, so all up and down that lid margin, and it will just debride. It literally melts it away, and that whole effect, it just inhibits those cytokines, so it just brings down the inflammation really quickly, really immediately. The eye whitens up, the patient isn't uncomfortable, and it doesn't sting or anything like that. And generally, it's a much more pleasant experience, and it really does debride in the same way as Blefex and Newlids does, without the discomfort, but with the added benefit of actually really inhibiting that cytokine action and having those polyphenols in there, that polysaccharide effect of really helping bring down that bacterial load, yeah, and that antioxidant effect.
And is it a one-off?
Like the Newlids, like the Goldspard, like the Blefex, no, because you're managing something. So it's a bit like saying, is this the only time I'm going to go to the hygienist? No, the hygienist is managing that whole that whole plaque situation. You're managing this. You aren't eradicating, you're managing. And do remember, you need Demodex there, and you're keeping that infestation under control. You're breaking that. The best way I can sort of like explain it is, if you think about what we've lived through in the pandemic, we were just literally flattening that curve, and that's what you're doing with this. You're flattening that curve, you're keeping it under control by using this. So it's not a one-off. All of these treatments here, including IPL, are just keeping it under control. So typically you'd be using Zest or Newlids or Blefex probably every 6 months, and they'd be doing some at-home management as well. So it'd be a combination of both. So they'd have, say, some Blefex, and then they would use some Zoccular or ZoccuShield at home to keep it under control.
Thank you, Ros. Any more questions?
Barry, do you want to unmute everybody, just see if anybody has anything to actually say or share?
Yeah, I can try and do that. I have to do it individually.
I just saw that question about are there any links to omega-3?
Yeah.
I think if you think about the fact that omega-3 is an anti-inflammatory, again, you're going to be doing the same thing. You're going to be hopefully, it's kind of like an oxidative stress, right? There's a lot of stress there. So just by bringing that omega-3 in, it's probably not a direct method, but it will help. Yes, because you're going to improve the quality of the meibum that is being produced. So if we go back to blepharitis and it being a quality and quantity thing, the quality of the meibum that you produce alters with age, and Demodex affects that. But it's not only Demodex that affects that, it's other factors that affect it, like diet. So when you take an omega-3, you're actually putting back in a lot more good omega, because we have quite a lot of bad omega in our diet. You're readdressing that balance. So therefore you are making the quality, so you're making the quality of the lids a lot better, because the meibum they're producing is a lot more, is coming out of their lids a lot more comfortably, if that makes sense.
Okay. Yeah, I'm having difficulty unmuting Ros, so we have to stick to the typed questions at the moment. We've got have patients say taking some improved their lids. What's your opinion on the peat wand?
The peat, yeah. I quite like the fact that you have something that is doesn't have to go in the microwave, because a lot less people have a microwave. I'm a bit worried about the fact that you're constantly moving it. So how much are you heating that area up? I have got peat wands in practice, and I've had a few mixed kind of results on it. Some patients really like it, some people don't. Has anybody else here got a peat wand, actually? Anybody else use them? Anybody got any suggestions on it? I don't think it particularly works too well with Demodex. I don't think it's really designed for that. As we said, really, we need to, if you're going to be, you know, killing Demodex, or you're really sort of like breaking that that cycle, then you really do need something that's a little bit more debriding and, you know, a little bit more targeted. But I guess if you're looking to heat up meibum and clean it away only, as in traditional blepharitis, seborrheic or whatever, then I can see that it would have its place. But I think something that would have a lot more consistent heat in there might be better, I would think.
Okay. Right. No other questions at the moment.
We had somebody else agreeing that they've had nice feedback, but Elizabeth agrees that really more consistent heat is better. Yeah, I think you're right, Elizabeth. It's about compliance, really. The fact that I think with the peat one, it's just easy, right? Because and it looks nicer, but I just don't know if it maintains the heat as well. I think the patients that I've had the most success with it are the ones that they don't have a microwave, and therefore they're having to put a heat bag into the oven, and that doesn't kind of work as well. But the others haven't been as good, is what I would say.
Very good. Yeah, okay. Any other questions for Ros? It doesn't look like it. Oh, hang on. When do you suggest patients use hypochlorous, and do you recommend bleeper wipes or blepha wipes, I think it must be, and how many times a day would you do lid cleaning? So when would you suggest hypochlorous?
I mean, hypochlorous is just like a really good cleansing agent, right? So a lot of my patients actually use it as a toner, because it just rebalances the bacteria on the skin. It just reduces inflammation, which is what your toners are supposed to do, but they have alcohol in them a lot of times, which strip away the bacteria. This is doing it in a lot more natural way. And it's a really nice atomizer spray, and it just spreads beautifully. And if you think about the fact that you're reducing the inflammation, you're making that environment less habitable for Demodex, because that's what we're talking about here at the moment. So it's another way of managing this problem. It doesn't, as I said, it doesn't kill Demodex in the way that T4ol and T-triol and ochre does, but it does make the environment less hospitable for them. So that's how I would use that, and it really does reduce the inflammation quite a lot. So you'd be surprised at how well it works. So I would start getting your patients to use it, and they just close their eyes, spray it on, leave it, let it dry, and go to bed. That's it.
And Jasper asks, what's the best combination of treatment that you recommend your patients, or you would recommend to patients?
For
I would imagine Demodex. If
So I tend to, the first thing I do is my whole clinic is really about a twofold approach. I do a lot of in-practice treatments combined with a little bit of home management for them. So if you've got Demodex, or even if you've got straightforward blepharitis, we definitely, first thing to do is definitely look at, and there's discomfort with that, then the first thing you want to do is debride. I mean, that's been there in history for ages. You've got, you know, you've got your golf spud there, which shows that. So either use this zest, which will just bring down the discomfort straight away, because it's like that. Remember, it's like that ibuprofen in a localized way. So you're just getting that, you know, reduction in comfort. You're debulking the bacteria. You're getting rid of the hatching site. All those eggs are gone, so you've broken that reproductive cycle straight away. And then they can go away and do a bit of management. And I tend to base that upon patient dexterity and patient type and lifestyle, right? So if it's somebody that's flying around all over the place and haven't got a lot of time, then yeah, get them to just rub on a little bit of ZocuShield, which is really easy to do. They don't have to sit there. They just, you know, put on a little bit of that gel, you know, 2 or 3 times a week, and that's going to help keep their Demodex under control. And then just get them to use a hypochlorous spray, which just keeps this, you know, just keeps the inflammation down. If they've got more time on their hands, then you can do more, right? They can have their own new lids at home device if they want to. They can use the wipes if that's what they prefer to do, which is more time consuming. It just really does depend on the patient, but I really do put a combination of in practice treatment along with a little bit of home management.
Okay. How often do people need IPL treatments?
That depends upon the patient, a bit like how often do people need new lids and zest and things like that. I think the first 3 sessions, you have about 3 or 4 sessions initially if you're using something like a luminous kit. And then you probably want to see how well they respond and see when you want to bring them back, usually about 6 months to a year.
Okay.
A blepharitis, I think somebody was asking about blepharitis. That has T4ol in it. And it's great. Demex also has T4ol in it. It's a foam, so that's quite nice too. And again, the ZocuShield is just a gel. That's really easy. So all those patients that have got kind of like poor dexterity, I tend to go along the things that are easy to manage. So the ZocuShields and your Demexes and things like that, which are just, you just tap them on and they're just not difficult to cope with. And if you think about the fact that these patients that are probably going to get Demodex infestations are probably going to be the people that are more diseased, so a little bit older. Those are the kind of things that you want to aim for. And hypochlorous is just easy to use, right? It's just a pump. It's not directional, so it's really straightforward.
Brilliant. Okay. Any more questions? I can't see any more coming in, Ros. Just thank you.
Oh, Elizabeth, thank you so much. I had a bit of a paddy in the middle of it all, so it was really good of you to say that, because it's been a long day and I kind of lost my way a little bit, but thank you very much.
Brilliant. Okay. All right. So are we all happy there? Yeah. Thank you for the ideas. Thank you. Just thank you.
Thank you so much, guys. I really, really appreciate that. Oh, thank you. Thank you, Jasper. Everyone's being lovely. Thank you so much.
Brilliant.
I hope you guys got what you needed from the presentation. I'm sure you've all got my email address as well. So if you need any, just drop me an email. I'll give you a call, or I'll get one of the guys to call you. Just remember that I only work part-time though, so I don't always get back to you straight away, is what I'm trying to say.
Yeah, excellent. So I think, Rosa, any questions? Obviously,
thank you, Christine.
People can email the body doctor as well, but please do remember that we will be sending a short survey that we would obviously appreciate your honest feedback. As I say, it helps us develop and improve our sessions. And following that email, you'll receive another email with a link to download your CPD certificate. So anything that we can do, any questions, then yes, please drop us an email. Ros, thank you.
No, thank you very much, guys. Thanks for listening. I've just brought up the C number and your QR codes, which you will get. Yeah, look forward to seeing you again soon.
Yeah, any future CPDs will email those out in plenty of time. Give you plenty of time to register. So hopefully we'll see you all again next time.
Thanks so much. Take care, everyone.
Thank you, Ros. Thank you. Thank you, everyone. Bye.